Yeah, so this is very important. Dementia is not only a public health problem currently, but also a big social crisis. I think as behavioral neurologists, this is the big challenge of our generation. And I think addressing the challenges that come with managing dementia will probably be a big legacy. So when you see how we are trying to address the problem of dementia, well, there are people who want to cure the disease, come up with new treatments, new therapeutics, new molecules that can be disease modifying, that can prevent the disease. But there are a lot of people who are already living with dementia who need treatment, and there is a trend of having those people left behind in clinical trials, because now the trials are focusing on people who are at the early stages of the disease. But we really need to pay attention to those people living with dementia. Those people, the burden is there. It's not only for the patients, but also for the caregivers. Essentially, everyone who has dementia will eventually have neuropsychiatric symptoms. Things like aggression, agitation, resistance to care, motor behaviors. So those symptoms cause a lot of distress. And the default, just because it's easy and it's convenient, is to treat those patients with medications. But medications are not 100% effective, and they come with side effects. They are basically chemical restraints. The Alzheimer's Association and several organizations, professional organizations, medical organizations recommend non-pharmacological therapies to be used as a frontline therapy. However, neurologists or doctors are not well versed in how to introduce these techniques, and this is what we're trying to do in this session. So we crafted a session that is about therapeutics in dementia, and we'll have a component of medications, we'll have a component of experimental treatments, including the anti-amyloid therapies that are now being introduced into the field. But we also thought that it was very important for clinicians, for neurologists, to have an understanding of the theoretical frameworks around non-pharmacological therapies, based on the evidence that we have, and then have some examples of how to deploy these interventions. Just bottom line, the two main interventions that we have is for which we have data efficacy are two. One is tailored towards caregivers, and it's basically caregiver education around the disease, psychoeducation, and also counseling, psychotherapy. Basically, let them talk about their stressful situation. Have a way to talk with a therapist and partner with someone. So those two interventions have high evidence of high efficacy for caregivers. And then for patients, what we want to emphasize, based on the evidence, is to create individualized programs of tailored activities, so person-centered. So this is where, I don't think you can get more into personalized medicine than this, because you need to know your patients, you need to know who they are, what the trajectory is, what the dynamics they have, what dynamics they have with their caregivers, and then based on that you craft, and what environment they live in, of course. This is you see that whole ecosystem, and based on that you create sessions of therapy that you can introduce with occupational therapies, for example. And you allow them to maximize their autonomy and let them still be part of their own world. So that's the bottom line. That's what we'll be trying to emphasize tomorrow.